I'm Harriette Van Spall, cardiologist and clinical trialist, and I'm here with Professor Stephen Nicholls from Monash University. He is here to present exploratory analyses of the SURPASS-CVOT randomized clinical trial. Welcome, Professor Nicholls.
Hi.
I wonder if you would start by giving us context for your analysis. Give us a high-level overview of SURPASS-CVOT.
SURPASS-CVOT is the first cardiovascular outcome trial of Tirzepatide. Tirzepatide is a dual incretin agonist. We've seen in early clinical trials that it has favourable effects compared to GLP-1 receptor agonists on a range of metabolic risk factors, weight, HbA1c, blood pressure, and lipids, for example. SURPASS-CVOT was an outcome trial conducted in patients with ASCVD and type 2 diabetes. For the first time, it was a diabetes outcome trial in this space that did not have a placebo comparator. Rather, it was an active comparator study between Tirzepatide and Dulaglutide, a GLP-1 receptor agonist that had previously been demonstrated to have cardiovascular benefit compared with placebo. And what we looked at there was conventional MACE endpoints. The primary objective of the study was to establish non-inferiority. And that's in fact what we did. We reported at the European Diabetes meeting a couple of months ago that Tirzepatide produced more favourable effects on the biochemical risk factors and was non-inferior with regards to cardiovascular death, MI and stroke, which then met the criteria for superiority, what we call a putative placebo. And then with another pre-specified analysis where we looked at the placebo patients from the Dulaglutide trial that had been conducted previously, we were able to kind of see what degree of benefit that would look like between Tirzepatide and placebo. So that was, from that perspective, in a non-heart failure setting, was reassuring and really told us that Tirzepatide was cardioprotective and at least non-inferior to a GLP-1 receptor agonist.
What was the rationale for the non-inferiority versus the superiority defined?
Well, this is a new frontier. We're conducting for the first time in a large clinical trial a active comparative study against a GLP-1 receptor agonist, and those are really good agents. To conduct, we could have conducted a placebo-controlled trial. We thought the right thing to do, given the increasing access to these therapies and the likelihood that they would become even more accessible during the course of the trial, was to not preclude patients from being on a GLP-1 receptor agonist. Also, it has implications in terms of the size of the trial. So a superiority study versus a GLP-1 receptor agonist probably would have been substantially greater to have to conduct.
So your trial population were mid-age adults with ASCVD, diabetes, and then some risk-enriching features?
Exactly. So they were patients about 60, predominantly male, 65% or so had coronary disease, the rest had prior stroke or PAD. These were people who'd had diabetes for an average of 14 years with a baseline A1C of about 8.4. These are the patients you'd expect to see in a diabetes cardiovascular outcome trial.
And tell us about the aim of this exploratory analysis.
So we pre-specified that we wanted to look at the outcomes in people with and without a history of heart failure. 20% of individuals described a history of heart failure. Now, we didn't require imaging, BNP levels or those types of things. So we recorded that like we were doing a standard CVOT. What we wanted to do was to compare the effects of Tirzepatide and Dulaglutide on all of the outcomes that we looked at in those with or without a history of heart failure. But we also then wanted to look at heart failuring. And the original analysis in SURPASS-CVOT was a composite of cardiovascular death and hospitalisation or urgent visits for heart failure. Given the fact that the SURPASS-CVOT study demonstrated non-inferiority for the MACE endpoint, but also showed a significant reduction in all-cause mortality. At the AHA meeting, we're going to present that heart failure composite in parallel. On one side, it will include all-cause mortality, and on the other side, it will be with cardiovascular death.
Sure. So the patients had been randomized to these 2 treatment groups. Tell us about your treatment effect in this exploratory analysis.
So from a metabolic risk factor perspective, we saw exactly what we observed in the main analysis, that whether you had a history of heart failure or not, a tirzepatide produced more favourable effects on HbA1c, body weight, systolic blood pressure, slowed the reduction in EGFR compared to dulaglutide. So biochemically, you got a bigger bang for your buck with tirzepatide. When we looked at the composite of all-cause mortality and hospitalisation or visits for heart failure, we saw less of those events in the tirzepatide group compared to dulaglutide in those with or without a history of heart failure. Not surprisingly, the patients with a history of heart failure, the event rates were higher, the absolute risk reduction would have been greater. For the combination of cardiovascular death and the heart failure events, we see non-inferiority in both groups, which is very much aligned with the original analysis. And then when we looked at the atherosclerotic outcomes, whether we looked at MACE-3, which was non-inferior in the original analysis, remains non-inferior for those women without a history of heart failure. When we look at the expanded MACE-4 endpoint, which is the other presentation at this meeting, which includes coronary vascularization, there are less of those events with tirzepatide compared with dulaglutide in those with and without a history of heart failure. And then the final comment around efficacy would be that whether you look at fatal outcomes, heart failure outcomes, or atherosclerotic outcomes, the event rates are considerably higher in those with a history of heart failure compared to those without.
Right. And you saw a treatment interaction based on the presence of heart failure at baseline. Did you not?
No, we see no statistical heterogeneity, but we're continuing to explore that. Now, one of the things that we did observe and we need to take a deeper dive on is SGLT2 inhibitor use. So at baseline in this study, 30% of patients were on an SGLT2 inhibitor. There was some drop-in of SGLT2 inhibitors over the course of study where patients being treated on average for 4 years. Given the fact that tirzepatide produced better reduction than A1C, not surprisingly, you see more SGLT2 drop-in in the dulaglutide group compared to tirzepatide, and that may have some implications with regards to heart failure outcomes. So we're gonna need to explore that to a greater degree. Yeah.
Fantastic. Any other takeaways from this trial and how it impacts practice?
So the only other 2 take-home messages in terms of findings, one, we have looked at a number of patient-reported outcome measures. This wasn't a heart failure study. It would be great to present a KCCQ here, which we know is often used in the heart failure trial setting, but we don't have that. But what we have seen with a number of the questionnaires that we applied were that those scores were worse at baseline in the people who had a history of heart failure, which probably isn't that surprising, and that over the course of the study, the tirzepatide patients did better than the dulaglutide patients. So we're seeing some quality of life assessments that seem to parallel what we're seeing in terms of clinical events. And then in terms of safety and tolerability, we had originally reported more GI adverse events in the tirzepatide group versus dulaglutide for the whole study, and we see that in those with or without a history of heart failure. So I think all in all, these are very consistent findings with what we see for SURPASS-CVOT overall. It continues to reinforce that this is an agent that produces a range of metabolic risk factor benefits. The clinical side is at least non-inferior to dulaglutide, and I think that if you look at outcomes that include all-cause mortality, and these are patients that can die to a range of kind of causes, perhaps the tirzepatide patients may do a bit better.
What are your thoughts on that reduction in all-cause mortality? What are some of the mechanisms?
Well, we see less patients with tirzepatide experience a non-cardiovascular death. When we looked at the non-cardiovascular deaths, a lot of that difference seemed to be death in the setting of infection. And that's actually very consistent with what we saw with semaglutide in the SELECT trial. So I know there's a lot of work being done to try and understand what's going on there. Well, it turns out these agents are pretty complex, and the mediation analysis, for example, it's very similar to what we saw in the SELECT trial. And I think that these are complex agents. They have a whole range of different kind of functional properties. And even if you look at the mediation analyses that are coming out from some of the trials like SELECT, I think what we're observing there are that there's no one mechanism that seems to be at play for why we're seeing the benefits. So why do we see a reduction in death in the setting of infection? We don't know, but it will be sure interesting to kind of look at that. But, as you know, and you look after these patients in the clinic, heart failure is a complex condition. These people, competing risk is a big deal. And it's, in fact, in a lot of ways, it's a much bigger deal in heart failure than it is in, say, the post-ACS setting. So it's not necessarily that surprising that as we kind of go beneath the surface of SURPASS-CVOT, that perhaps we're going to see some really interesting observations with regards to tirzepatide that we wouldn't have seen with regards to just the primary MACE endpoint.
Really highlights the importance of exploratory analyses, which fuel further hypotheses and investigations to uncover important mechanisms that we may not otherwise detect.
It does. And if you think about this space, we've got nice data now with GLP-1 receptor agonist and tirzepatide in obesity-associated heart failure, improvements in 6-minute walk, improvements in KCCQ outcomes, some suggestion of less events in, at least with tirzepatide. But I think what all of this is saying is there needs to be a really big prospective CVOT focused on heart failure in people with legitimate heart failure to have a look and see what tirzepatide does. And hopefully we'll see that in the not too distant future.
Right. So there's lots of ongoing trials of incretin therapies in this space, and we look forward to unearthing those results as well. Thank you so much for joining me today for this discussion. Congratulations on your presentation at the late breaking stage tomorrow at AHA 2025.